Hello everyone, my name is Maddie WIlton-Clark. I'm in my final year of medical school at the University of Calgary, and I'll be starting my residency training in physiatry at the University of Calgary in July 2021. This case report was written with Dr. Paul Winston from the University of British Columbia. Our case is distinguishing pain and loss of range of motion due to complex regional pain syndrome from lower motor neuron injury after cervical trauma. This case involves a 75-year-old male with a spinal fracture, cervical cord contusion, upper and lower limb weakness, and paresthesias immediately following a motor vehicle crash. He was originally diagnosed with a spinal cord injury, but follow-up examination was more compatible with a lower motor neuron injury in the right upper limb, as his clinical presentation had markedly improved by day 5 post-injury. A decision was made to monitor and follow. At 4 weeks post-injury, the patient showed improved power. The electrodiagnostic assessment of the right upper limb found normal median and ulnar motor and sensory responses on nerve conductions, as well as the lateral antebrachial cutaneous nerve. EMG revealed positive sharp waves and fibrillations in the deltoid and biceps with significantly reduced recruitment. The supraspinatus revealed reduced recruitment but no fibrillations, and the triceps, pronator teres, extensor digitorum, and the first dorsal interossei were all normal. At this early stage, these results remained consistent with a lower motor neuron injury. The differential included an injury to the upper trunk of the brachial plexus, the nerve root, or the anterior horn cell injury from the cervical spine injury, and the MRI did not suggest overt spinal nerve root trauma. 2.5 months post-injury, despite clinical and electromyography-based recovery to the original neurologic injury, the patient presented with decreased range of motion, severe pain, and inflammatory features in his right upper limb. His right hand and wrist were warmer than the left and sweating. He was unable to make a fist, as demonstrated in this photo, and his right hand was shiny and grossly swollen. He had significantly reduced range of motion at the right shoulder, elbow, wrist, and fingers, with severe pain with movements of these joints. So these photos demonstrate his inability to fully extend at the elbow, his inability to make a fist with his right hand, and the edema and his inability to fully extend his fingers. The follow-up EMG showed ongoing positive sharp waves to the biceps, deltoid, and pronator teres, with reduced but improved motor unit action potential recruitment, which coincided clinically with the notable gains in power, particularly in the deltoid. The patient met Budapest criteria, and he was diagnosed with complex regional pain syndrome type 2. The patient was treated with a tapering regimen of prednisone, which led to complete resolution of his new symptoms. This video demonstrates the patient's drastic improvement in his ability to make a fist and to open and close his hand. By 2 months after he had initiated prednisone, the patient experienced complete resolution of his symptoms. The patient continued to make ongoing improvements with time. This case highlights the importance of serial clinical examinations in trauma patients and emphasizes the importance of early recognition of CRPS, as well as the potential that corticosteroids hold in treatment during the early stages of the syndrome. Thank you very much for your attention during this presentation.